Good morning and welcome to the weekly dementia blog. My name is Dr. David Hutchings, and as always, these are being sponsored by SpectraMed. Just as a reminder, we are conducting a lecture with the Alzheimer's Association on, I think it's November the 17th. So if you want some more information on that, you can certainly reach out to me about that. So we're really excited to be speaking with the Alzheimer's Association and their conference for the fourth or fifth time this year. So obviously, we're talking about some really great information, updated research, clinical trials, vaccinations, and multitude of different topics. So looking forward to that presentation. So we're going to continue our three-part series on sundowning. Sundowning in dementia or in Alzheimer's disease, or no matter the type of dementia, can be an extremely complicated process, sometimes very difficult to treat, and sometimes actually very easy to treat. And we had talked about last week in terms of the physiological aspects of why we see sundowning happening, the decreased levels of melatonin, the decreased functioning and levels for the suprachiasmatic nucleus, and these things playing together not only help us go to sleep but keeps us asleep. So those are more of the physiological or the more medical or chemical things that we would relate to sundowning. So this week we want to talk about environmental, and there could be a multitude of things here. So when I see patients that have sundowning issues, what I try to do is try to look for patterns. What time of day is this happening? And kind of look at the situation around it before we immediately try to start medicating it. So number one, I would say that definitely activities during the morning times. If we have a lot of activities during the morning time, we can see some afternoon fatigue. It could be poor lighting within the patient's home and their room. So if the blinds are shut or something like that, then obviously they're going to think it's evening time, and we can see some of the agitation and behaviors begin to emerge. We could also have maybe staff changes. I see this sometimes, a lot of times in the memory care facilities. They can have staff changes, and all of a sudden that kind of can create some agitation. Or it can be a certain patient activity or even a staff member that the patient is kind of their trigger. And so we always look for triggers. And so if we see that it's happening around a certain patient or around an activity or even a staff member, then that's more of our trigger. We also can see that if we have a higher level of activities in the morning, we see afternoon fatigue. So that could be something else. We may have recreation and all these things that we're doing in the morning that creates that afternoon fatigue. This sounds kind of crazy, but it can simply be boredom as well. So we want to make sure that the patients are being stimulated and they have something to do. And in that stimulated environment, it's incredibly important. I've talked about this in previous blogs. It's incredibly important for us to have a structured environment day after day after day. This helps the patient feel more control, and also we're able to use that structure to allow the patient to know what's coming next in their day, which allows them to have some decreased anxiety and fear, and some of the other behaviors that we would see with sundowning. And lastly, we've talked about this over and over and over in terms of the importance of sleep hygiene. So sleep hygiene is very important. So if we see a patient that has poor sleep at nighttime or intermittent sleep, whether it's from the dementia itself or, like we talked about last week, restless leg syndrome or periodic leg movement syndrome, these are things that we could also contribute to sundowning. And then lastly, medications. We're really quick to prescribe so fast, but some of the medications themselves can be impacting sundowning. So if we have, maybe antidepressants or antipsychotics or anticholinergic inhibitors, those types of things can certainly have issues. But I will say the drug of choice that should not be a drug of choice is anything in the benzodiazepine class. So that's going to be your Xanaxes, your Klonopin, your Ativan. These medications, along with some of the other antipsychotic medications, when we're giving them to the patient who's experiencing sundowning, they work fast, and then the body will metabolize them very quickly. So as they break down, now we're back to where we were before. So definitely there are other medications out there that are wonderful medications when it comes to dealing with sundowning and helping control that. One of the ones I use very often is Seroquel. It seems to work on the majority of patients to control some of the sundowning. So if we can really focus on the physiological aspects of it, making sure we're choosing the right medication, and then looking at the environment itself, the chances of decreasing sundowning and the behaviors that we see with that decrease dramatically. So we're going to continue the series. I know it's very important. I get a lot of questions on sundowning, so we're going to talk a little bit more about that next week. Wrap up that series, and as always, we'll continue another one. So thank you for joining in, and we'll see you again next week. Thank you.